Yeah, thank you very much, Thomas, for these very clear explanations and the smooth transition to the next and final lecture. I would now like to explain the reflections of my colleague, Mrs. Ursula Frede, and myself on spiritual aspects in the biopsychosocial context and their significance for interdisciplinary multimodal pain therapy. And you will probably be able to draw some parallels with the presentations given by Tove and Professor Büssing this morning, which I now will refer to the chronic pain. Why should we even consider spiritual approaches in pain management? That is the first question that we asked ourselves. The IMPT, the interdisciplinary multimodal pain therapy, is primarily based on three pillars: the biomedical, the psychotherapeutic, the physiotherapy and occupational therapy pillars, supplemented by sociotherapeutic and nursing measures. The widely promoted aim is to improve the objective and subjective functional ability of the people concerned. This goal alone must be called into question, because there are people whose functional abilities can only be improved to a limited extent or not at all, but who will still have to live with pain for many, many years. Even pain sufferers who achieve a certain degree of improvement in their functional abilities suffer from a multitude of restrictions in their lives. Many of them, for example, lose their jobs and thus their financial security. Social contacts decline. Life plans fall apart. Their sense of self-worth and identity is shaken. In short, their lives are thrown into disarray. Chronic pain is not merely a health issue that can be attributed to an illness. Rather, it permeates every aspect of life and shatters the very existence of those affected. Two key aspects stand out in this regard: the issue of despair and that of finding meaning and new orientation. First of all, regarding the aspect of despair. A pain patient is quoted as saying, "In the past, I could only imagine how desperate someone must be to take one's own life. Now I experience this despair firsthand, a despair that takes my breath away, paralyzes me, makes me cry, makes me silent." And secondly, the aspect of reorientation is described by the former mentioned Elizabeth Petro, a doctor who herself became an affected patient. "My inner coordinate system no longer corresponded to the current situation. What could I continue to use to orient myself within myself and in the outside world? Which characteristics could I trust? Which abilities would return?" To date, the IMPT has focused on activation and exercise-based approaches, considering biomedical, psychological, and social factors. These measures are helpful and important, no doubt. However, they are not always sufficient, because chronic pain is not just a disorder, but also an existential challenge for many patients. Pain therapy should aim to treat the whole person and should therefore not be limited to a biopsychosocial factor, but should also take spiritual components into account. But what exactly is meant by spirituality? In everyday language, terms related to spirituality are often used in spiritualist, metaphysical, and esoteric contexts or equated with religion, as Thomas explained before. Even in specialist literature, there is still no uniform definition. However, all descriptions use terms that refer to human identity, especially to our need for meaning and a fulfilled life. On this basis, we understand spirituality as that which sustains a person's life and gives it meaning and significance, regardless of church affiliation or religious orientation. Religious and spiritual topics have long been taboo in medicine and psychotherapy. Since around 1990, however, there has been a growing body of research suggesting that taking spirituality into account can have a positive effect on people's physical and emotional health. In the field of medicine, spiritual issues have so far been addressed primarily in the context of palliative care. It is only in the last 15 years or so that there has been an increase in research on pain patients who are not immediately approaching death, which I find very important. The results can be summarized as follows. Chronic pain triggers crises of meaning and identity in many people. And spiritual activities increase the well-being of people suffering from pain, leading to improved life satisfaction and increased pain tolerance. And very important, most of those affected would like spiritual aspects to be included in the treatment. Therefore, if chronic pain leads to existential crisis of meaning and identity, and spirituality can make a decisive contribution to overcoming crises of this kind, spiritual aspects should be taken into account in pain therapy alongside biological and psychosocial aspects. So, what could be achieved by incorporating spiritual intervention into pain management? On the one hand, by mobilizing their own resources, those affected receive support in giving meaning and significance to their lives and in stabilizing their sense of self-worth and identity despite manifold external changes in their situation. On the other hand, a further goal could be to identify stressful spiritual beliefs, for example, pain as a punishment, in order to better understand certain reactions and support patients in developing more relieving perspectives. And the third goal can be seen as the overarching concern of taking spirituality into account to find support and orientation within themselves and to maintain a sense of their own world, regardless of the cause of their pain. Let us now turn to a possible practical implementation in everyday clinical practice. Who could be responsible for incorporating spirituality into pain therapy? And who was in the talk of Tove this morning? She answered it clearly, the nurses. They should be the ones. My answer is a bit different, and we can discuss that later on. Gian Domenico Borasio, one of Europe's leading palliative care physicians, has said the following about incorporating spirituality into palliative care. Spirituality is teamwork. This statement applies equally to the care of pain patients who are not about to die. Interviews with those affected have revealed the following. People suffering from pain can Imagine all specialists from all disciplines as contact persons for spiritual issues within the framework of their treatment process. So, written by Redke. One female patient, for example, says, "The nursing staff on the ward, they have the most contact. So, a physiotherapist, I can stand naked in front of her, which I don't necessarily like doing with a doctor." Patients are well aware that not all professionals have the necessary skills or opportunities to deal with spiritual issues and needs in depth. Nevertheless, we should be aware of one thing: spiritual experience and thoughts are deeply intimate and private. Talking about them requires trust in the person you are talking to. But that means that most patients choose who they want to talk to about spirituality. But what do experts think about the question of whether spirituality should be included? The answer can be found in a study conducted by Horst Redke and his colleagues in 2021. In this study, 34 experts from 5 study centers in German-speaking Switzerland that treat pain patients were interviewed. When asked who they thought should be responsible for integrating spirituality into pain therapy, the professionals interviewed suggested distinguishing between general and specialized support. General and specialized support. We would like to take up this distinction because it meets the needs of patients and those providing treatment. What does that mean in concrete terms? All professionals who deal with people suffering from pain should be able to provide general support. Put simply, this type of support involves being open to a patient's spiritual concerns, listening to them, and engaging with what they say. General support also includes being aware of the limit of one's own competence, should a patient wish to engage in a more in-depth discussion of a spiritual topic. Specialists in the fields of example given clinical pastoral care and psychotherapy are qualified to provide special support. There's now a wide range of part-time continuing education courses available for this specialized support, including block courses, weekend courses, and online courses. Regular supervision and further training are essential for both types of support. On the one hand, this is to avoid being overwhelmed. On the other hand, it is to train professionals in how to respond to patients' spiritual concerns. Previous effectiveness studies indicate that even short training courses in spiritual care have a positive effect on the spiritual competence and well-being of professional. As we heard this morning, this is a very, very important theme, as Professor Büssing explained us. There's sometimes a fear that taking spirituality into account could tie up unnecessary resources. Also about that, Professor Büssing was talking this morning. The opposite is, for our opinion, true. In the long term, taking spiritual concerns into account may even save time, as it can help us to understand patients better and provide them with better support. Some professionals may feel overwhelmed by the existential suffering of many patients. I don't know what to say. However, the task of the caregiver is not to have an answer to every question or a solution to every problem. Now let's move on to the last question. In our final point, we would like to consider how spirituality could be incorporated into an interdisciplinary multimodal pain concept. Here, we will limit ourselves to behaviors that are important for this mentioned general support. That is, for the kind of support that does not require psychotherapeutic or pastoral training. The intervention described are by no means new. However, they are essential for enabling people suffering from pain to address their spiritual concerns. First point. When supporting patients as they grapple with the existential challenges of their situation, it is not specific techniques that are crucial, but rather a certain inner attitude which is characterized above all by the following aspects: willingness to engage with personal meanings and values, openness to the spiritual concerns of people suffering from pain, combined with a willingness to engage with them, trust in the resources of the patient, however buried they may be, and tolerance and respect for views that differ from one's own. And lastly, sensitivity to the moment when the limit of one's own competence in spiritual matters are reached. Being authentic means, above all, acting in accordance with your own values and being open and honest with yourself and others. The prerequisite for authentic behavior is the willingness to examine your own values and to become aware of what is really important to you in life. Your own authenticity is particularly important when you feel overwhelmed by the spiritual concerns of a person suffering from pain. Most patients are understanding when they are referred to another member of the interprofessional team for this reason. For example, a pain patient said, I would think it was shameful. I would not think it was shameful if a doctor said, my expertise ends here. Integration of spiritual history. If a patient does not talk about his or her beliefs, values, or initiative, we can ask about it. The following questions are particularly important as the patient's answers can provide clues as to how best to support them. If you don't want to use firstly a questionnaire, you could ask these questions. What is really important to you in life? What do you hold dear? And who or what gives you stability in life? Maybe you feel remembered of that was what Tove mentioned this morning. Questions of this kind allow us to learn about the spiritual aspects of the person concerned without having to use words such as spiritual or spirituality at all. An anamnesis of spiritual orientation is helpful in two ways. On the one hand, it can help to activate the patient's resources. And on the other hand, stressful spiritual beliefs can be identified and incorporated into the treatment. For example, there are people who experience their pain as a test or as an atonement for past wrongdoing. Other patients are convinced that certain therapeutic measures are incompatible with their beliefs. Beliefs of this kind can become an additional challenge, complicating or even preventing the use of therapeutic measures. And that's why we should ask for them. A very important point is the point attentive listening. In order to talk about spiritual concerns, pain patients need to feel that they are being taken seriously and respected. This experience is conveyed to a person primarily by listening to them. Seems very easy. But when asked what behavior they would like to see from their doctors and therapists, one pain patient said, "Yes, I think it's just important to listen carefully to what the patient is saying, because not everyone is a textbook case where you can say they have the diagnosis, so this or that must help. For some people, something else is needed. I think that's actually the most important thing, listening and taking them seriously." One of the main pillars of interdisciplinary multimodal pain therapy is education. Its central aspects are information, counseling, training, and instruction in functional activities. This means that the specialist takes on the role of the expert while the patient is in the role of the student. Listening means stepping back from the role of the expert, at least for a moment. Not easy for some of us, which are thinking they have the role of expert and have to live it. Being open to everything the patient reports without judging or interpreting it, without interrupting them, and without already thinking about the answer you might give. Education is important, yes, but it usually represents only the second or third step. The first step is almost always to acknowledge and address the patient's despair, grief, and fear, and to engage with them. With our education, we are too fast for many patients. We are already in the future, while those affected are usually still in the past. The importance of giving patients time to grieve is highlighted by the words of, again, Elizabeth Petro. "The greatest comfort for me was when I felt that I was being taken seriously and understood in the specific situation, and when I sensed that the other person was willing to engage with me." The capacity to endure suffering. For many people, dealing with chronic pain causes them to question the meaning of their lives and their pain. Existential crises are not always directly addressed, but are hidden behind questions such as, why do I have this pain? What is the point of it all? Often the question why or what for is not actually a question, but rather a cry of despair, as you heard it just in the talk of Thomas. In the face of illness and pain, a cry of despair. At the limits of their own influence, caregivers can often do little more than simply be there. When a patient asks, for example, why is God doing this to me? Or what is the point of all this? They are not demanding an explanation of God and his actions or a meaning for their suffering. What they need is someone who can bear these questions and the suffering hidden with them, someone who will remain with him or her even when the suffering is great and the prospects of relief are slim. Pain patients know that this endurance is not always easy. One person affected by this says, "It also takes strength on the part of those accompanying the patient to be able to endure what the patient has to endure and to accompany them calmly instead of resorting to offers that are unrealistic at the present time." When a person suffers from chronic pain, several pillars of their identity are shaken. The physical and emotional presence of a professional and their unwavering presence, even when the patient talks about their despair, can convey to them that they are still a person who is being noticed. Ultimately, enduring means nothing more than this, affirming the patient's existence. Person's search for meaning is a deeply spiritual question, as finding meaning is considered a central feature of spirituality. The search for meaning in a life with chronic pain is an individual journey and therefore always a question of a person's identity. You heard that question already before. What kind of person do I want to be with this pain? This is the core question that a pain patient may ask him or herself. Answers to this question arise from the values of the patient, from their connection to what sustains their life, what gives them orientation and support. Questions such as the following serve to activate these values. What characteristics, interests, and concerns define you as a person? And what in your life are you still proud of today? What would you not want to change under any circumstances, or who or what helped you through previous crises? And what do you want your family and friends to remember about you? Activating values promotes the patient's awareness of what constitutes the core of their personality and strengthens their confidence that their life will retain meaning and significance, regardless of whether their functional ability improves, deteriorates, or remains the same. The role of a professional in dealing with the spirituality of people suffering from pain is different from that of dealing with their pain. Faced with the patient's despair, grief, and fear, there's a great temptation to prescribe medication or suggest a particular coping strategy. However, there are situations where neither of these things help, and that is difficult for us to accept. What does help, however, is to become a compassionate companion, at least for a moment. And another thing, incorporating spirituality into pain therapy does not require religious affiliation, knowledge of theology or philosophy, or sophisticated techniques for dealing with questions of meaning. Basically, it only requires an attitude of respect for the values of the patient and a willingness to engage with their thoughts and feelings. Those affected do not expect answers to their spiritual questions and needs. What they want above all else is to be able to express their own experience of suffering in the presence of someone who will listen and convey to them, "Yes, I see your pain." In addition to this clinical and practical approach, there are also questionnaires on this topic which can support. Here you see a small selection that you are likely to be very familiar with. I would particularly like to highlight the short interviews by Büssing, the spiritual needs questionnaire that he introduced this morning already, and the questionnaire on spiritual resources and burdens developed by the group of Professor Penkeller. Looking ahead, we plan to conduct further research into this extremely important topic, initially as a part of a pilot study in the nursing sector and subsequently as a part of larger scale investigation into its integration into the IMPT. Coming to the conclusion. The key to dealing with the spirituality of a person suffering from pain is to establish a relationship in which they feel accepted and embraced. The relationship is a prerequisite for any conversation about spiritual matters to take place at all. The role of the caregiver expands from that of an expert to that of a companion. And the key to this support is the effort to engage with the patient and their experiences. We do not have to find solutions to our patients' questions and needs. However, we should be able to tolerate these questions and needs and thereby convey to them. Patient may lose their functional abilities, but not their dignity as a human being. And I thank you very much for your attention, and we are now happy to take any questions or comments that you have.